symptomatic venous disease. So once you reach to this point that patient is having active venous symptomatic disease, so you have to ask yourself for two questions: whether the disease is infrainguinal or it is suprainguinal, and whether disease is only pertaining to superficial venous system or disease is having deep venous component as well. So if the disease is just pertaining to superficial venous component and it is infrainguinal, you will just offer the patient the management of varicose veins, which just subsequently will touch that. And if the disease is having suprainguinal component as well, you are seeing varicosities atypically found over the anterior abdominal wall, or leg is swollen, or atypical venous ulcers, or the history of previous DVT. So you have to see the further investigations like CT venogram or catheter venogram, or in special cases intravascular ultrasound. So CEAP classification. CEAP is a universally accepted model of assessment for varicose veins. And what is CEAP? It is comprised of clinical, etiological, anatomical, and pathological aspects of varicose vein disease. Now, it is such a comprehensive assessment that after doing all the history, examination, and investigations, primary investigations, sophisticatedly higher investigations, you have to brought the patient to see. So it is very important to see or to know the CEAP classification. In clinical aspect of CEAP classification, we have C1 to C6 grade, in which C1 is telangiectasia, C2 is disease, varicose veins. By varicose veins, we mean dilated, tortuous, superficial veins of more than 3 millimeter in size.
More than 3 millimeter.
So C2 disease is varicose veins, C3 is edema, C4 is skin changes, and C5 is healed venous ulcer, and C6 is active venous ulcers. And in etiology, you want to know whether these varicose veins are congenitally present or they are primary or secondary varicosities. And in anatomy, you want to know the system involved, whether superficial or deep. And in pathophysiology, you want to know whether the pathophysiology is obstruction or it is reflux. So, after all the assessment of your patient, which came to your OPD with symptoms of leg due to veins, you took history, you did examination, you did all the investigations, and now is the time to sum up all the information which you gathered from that patient in this CEAP classification. And here you can see C2, E, P, A, S, and PR. That means superficial venous system varicosities secondary to reflux. So this code, if you write, you send your paper to America, UK, Canada, Australia, it is universally known that this patient is having venous symptoms, superficial venous systems, reflux, leading to varicose veins. Similarly, you can, whatever your information about the patient comes, it might be C4, it might be E secondary, it might be P obstruction. So all the aim so far was to reach to this point. History, examination, investigations, everything was to reach to this point. So once we have reached here, so what is logical next step? You have to give this patient something, some treatment. So for the treatment of superficial venous system, But European Society of Vascular Surgery guidelines, they suggest you have to treat all the symptomatic superficial venous system disease upfront. Once patient is symptomatic, he or she comes to you, you have to treat them. Only C3 disease, where is edema, you just have to probe the edema first for other causes of edema. And you have to rule out other causes of edema. And once they are settled and edema turns out to be venous, then you will treat that patient as well. Now, what are the interventions you can offer to this patient? There are surgeries which you all know, classical flush ligation, stripping, stab avulsions, and then for perforators, subfacial endoscopic perforator surgery. These all are radical measures. These are surgical procedures. Then comes thermal ablation. Now, thermal ablation is basically ablating or destroying the vein with heat. So in thermal ablation, we have radiofrequency ablation and endovenous laser treatment. In both the cases, heat is being used, only the source of heat is different. In radiofrequency ablation, source of heat is radiofrequency. It has separate generator. In endovenous laser, as the name tells, laser is the source of heat. And otherwise, complete procedure is same. Just the difference is the generator and the catheter. Whole principle, whole procedure. So you learn one, you learn the other as complementary. And mechanico-chemical ablation, cyanoacrylate glue, these both options, they are non-thermal ablation. They also ablate the vein, destroy the vein permanently, but they are not using heat as the vein. And then catheter-directed foam sclerotherapy and injection foam sclerotherapy. These are basically chemical ablation of your veins, so in which you are selecting an irritant to varicose veins, endothelium. And in Pakistan, we are commonly using sodium tetradecyl sulfate, which is a detergent. Now, what is the purpose of intervention? Purpose of intervention is to exclude the varicose vein from circulation. Diseased vein has to be excluded from the circulation because diseased vein is producing symptoms. And this purpose you can achieve through all these what I have shown you. Now, what is to be selected out of this previous menu? So what European Society of Vascular Surgery recommends us? You have to select endovenous thermal ablation. May it be radiofrequency ablation, may it be endovenous laser ablation as first choice. This is level 1A evidence. It is even superior to open surgery and definitely from foam sclerotherapy. And again, what would be the best amongst the two? They have given this discretion to treating surgeon, whichever system he has in his setup, he can choose either RFA or EBL. For small surface venous system, yes, again RFA or endovenous laser system is preferred over open surgery and foam sclerotherapy. Endovenous laser treatment or RFA is limited to truncal veins till knee joint, because below the knee joint, the vein becomes so close to saphenous nerve that heat, whichever you are giving either through RFA or through laser, it destroys the nerve as well. So patient complaints, paresthesias, pain, and all sort of, quite discomforting symptoms for rest of life in many cases. So once you have done varicose vein treatment till thigh or knee, so what to do for the below knee segment? So you have to do either multiple stab emulsions or you do foam sclerotherapy. And whether to do them at the same setting once you are doing radiofrequency ablation or in separate appointment, it is basically decided through shared decision making with the patient. You have to sit with the patient, you have to explain him all the things, and if he says that he wants to have both the procedures concomitantly, you will offer that. Or if he says he just wants to have proximal procedure first and the injection or stab emulsions later on, both are valid. So, in every disease, you should try to follow this model of shared decision making, in which you basically guide the patient. You educate the patient and then you guide the patient to reach to a conclusion what is good for you, and you invite the questions and you invite the apprehensions of the patient so that you can clarify them and so that he can choose an intervention in which he also feels that he has some stakes. Now, with all these, we'll start radiofrequency ablation. We'll touch rather radiofrequency ablation. Radiofrequency ablation is basically indicated in all the, you have seen, primary varicose veins and contraindicated in aneurysmal vein trunk. We generally don't use aneurysm for the veins, as aneurysm is increasing diameter more than 1.5 times of a vessel. But since veins are very compliant channels, they don't have one diameter. At times they are 3 mm and they are perfectly normal in size. And the same vein can be 6 mm and it is perfectly normal, depending upon your hydration status, your ambulatory status. So if vein is significantly larger in size, so RFA is generally not recommended, or EBLA, because catheter tip does not get contact with the vein wall. So that can lead to failure of the treatment. If main trunk is tortuous, in tortuous main trunks, it is difficult to negotiate the catheter easily. And at times, you have to do multiple punctures at multiple sites. Multiple branches, again, they pose you hindrance, as in branches, once you are maneuvering your catheter inside the vein, despite a good caliber, the branches, they invite that catheter in them and your junction is missed. Or the vein is partially thrombosed. So all these are contraindications. So in radiofrequency ablation, RFA system, or even this laser system, they both have a generator, they have a catheter, they have a foot pad, and you use them. This is their assembly. And for getting access into the vein, what you can do is you select a vein point around the knee joint, may it be above the knee joint or below the knee joint, but it has to be a branch-free segment. You select the vein, you just can do either through Schrödinger technique, puncture the vein, and then put a wire, and then do all the things over the sheath. Or you can do a venous cut down of small size, 1 or 2 mm, 3 mm incision, and through that incision you can deliver the vein, and for that you don't need a sheath. You just have to go inside the vein with that catheter, and you straight away put in the catheter, and that catheter has to be parked till saphenofemoral junction, just 2 centimeters from the junction. in the great saphenous vein, not beyond the junction or at the junction, because in radio frequency ablation, the catheter tip is the filament which is emitting heat, and heat is emitted at 120 degrees centigrade within no time. And at 120 degrees centigrade, I don't think so body's any tissue can be alive. So it thermally destroys the collagens, proteins, endothelium, and simply, if you allow me to say, the vein will turn into an ash car. So you just withdraw the catheter periodically and you see the vein behind is no more a vein, it is just a scar. So you have to be inside the vein either through puncture technique or through incision, and venotomy would be done, or it can be through major open technique. You can, if you see that it can be, very superficially accessible, so even you can do it through a blind puncture. Ultrasound, if you have, that will facilitate in obese patient to mark the vein and to navigate your needles. Now, once your catheter is placed 2 centimeters from the junction, next step is to anesthetize the vein. And for that purpose, we use Tumescent anesthesia. Now, that Tumescent anesthesia is actually a large volume of anesthesia, which we give through 4 or 5 pricks using 20 gauge spinal needle. The Tumescent anesthesia is made through 1 liter normal saline, 2 ampules of lignocaine with adrenaline 2%, about 40 ml of lignocaine with adrenaline 2%, and 12.5 ml of soda bicarb. That soda bicarb is to reduce the sting of local. And with this large amount, you give Tumescent. And what does Tumescent do? First, it gives you a pain-free procedure. Secondly, it creates a heat sink around the vein, because 120 degrees centigrade temperature does not just limit to the vein. It can burn tissues around the vein. It can burn deep vein, it can burn saphenous nerve. So this Tumescent anesthesia provides a heat sink. So once heat travels to this fluid, it gets cooled down. Second thing, it separates the vein from surrounding structures. And we give this Tumescent anesthesia in the perivenous space, which you will see once we will be demonstrating. Sir, we give 2 lignocaine, 2% with adrenaline in 1 liter of normal saline and 2.5 ml of soda bicarb, and it is ready, sir. जी सर, यानी आपका ये 50 cc हो गया और 950 ml आपका नॉर्मल सलाइन हो गया सर, तो ये 1 लीटर का आपके पास है, and you have sufficient Tumescent to give even in both hands. सर एक ही ड्रिप में डाल दें या उसको हम अपनी एक जो प्रोसीजर ट्रे है उसमें डाल देते हैं सर, बिल्कुल इंशाल्लाह सर हम आपको इधर डिमॉन्स्ट्रेट करेंगे. So this is how you do it. And then once Tumescent is done, you just have to give command to the generator by pressing the foot pad, and in less than 10 seconds that vein, that catheter will emit 120 degrees centigrade heat. You will press the vein either through ultrasound probe or through a gauze manual. Yes. So you will periodically keep on removing this catheter downwards, and the vein will be, turning into ash bar. So this is how you do. And once you are done with RFA, you have to give anticoagulant single shot injection flaxane we prefer 60 milligram subcut stat. Once you are done with RFA and you apply a compression dressing and you send the patient for 15 to 20 minutes walk straight from the procedure table. So if you have to do a concomitant below knee varicose treatment as home sclerotherapy in the same setting, then after doing this RFA, you won't apply multi-layered compression bandage, you will wait and then you will switch towards the foam sclerotherapy. So, सर एंटीकोएगुलेंट इसलिए कि हमने एक क्लॉट एक वीनस सिस्टम के अंदर बना दिया। अब उस क्लॉट